Good afternoon, everyone. A critical topic that touches the lives of millions around the world is the intricate and often intertwined relationship between mental health and chronic diseases. My topic for today, Interconnected Realities, Mental Health and Chronic Diseases, delves into the complex connection between these two significant health issues. But in order to recognize this connection, we need to understand mental health conditions and chronic diseases individually. The World Health Organization defines mental health as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. Mental health has intrinsic and instrumental value and is integral to our well-being. On the other hand, mental health conditions, which are often referred to as mental illnesses or mental disorders, are defined as clinically significant disturbances in an individual's cognition, emotional regulation, or behavior, which is usually associated with distress or impairment in important areas of functioning, including thinking, feeling, behavior, and mood. Using data from schemes in the Insight universe, the 4 major mental health illnesses were investigated. Trends in mental health conditions, including anxiety, depression, bipolar, and schizophrenia, were analyzed over the past 10 years based on members' claims. Conditions were identified using ICD-10 codes, and the prevalence of each condition was looked at. From 2014 to 2023, the prevalence of depression increased from 4.5% to 6.9%, which is a 50% increase in prevalence. This increase was particularly large in 2019 and did not decrease after. The high prevalence in 2020 and 2021 may have been associated with the COVID-19 pandemic. This trend in prevalence can then be broken down by age and gender, where age looks at beneficiaries of a particular age in a specified year. The increase in prevalence was largest among the young beneficiaries, where prevalence increased by 1.9 times for beneficiaries below 20, as well as those between 20 and 40 years old. And when looking at this trend broken down by gender, the prevalence is highest among females. The prevalence of anxiety increased from 3.3% to 4.4%, which was a 36% increase in prevalence. And similarly to depression, this increase was particularly large in 2019 and 2020, which may have also been due to the pandemic. There was a slight drop in 2022 and 2023, but prevalence still remains higher than the pre-pandemic years. When broken down by age, the increase in prevalence was again largest among young beneficiaries, where prevalence increased by 1.8 times. And when broken down by gender, prevalence is highest for females than it is for males. Over the last 10 years, the prevalence in bipolar disorder increased by 55%. The trend in prevalence broken down by age shows that prevalence increased the most for lives over 60, but prevalence is highest among 20 to 40-year-olds. And the trend in prevalence broken down by gender shows that prevalence is once again higher for females than it is for males. Schizophrenia has the lowest prevalence of the 4 mental health conditions that we analyzed, and over the 10 years, the prevalence increased by 22%. As before, the increase in prevalence was largest among the young beneficiaries when looking at the age groups. And in contrast to the other mental health conditions, the prevalence is now higher for males when looking at the gender breakdown. The largest increase in prevalence for all the conditions may be associated with an increase in demand for treatment in the population, especially among the young. Alternatively, it may be associated with higher demand, whereby patients are referred and treated for these 4 conditions more commonly than they were in the past. Diagnosis creep is another explanation for increases in mental health diagnoses in terms of expansion of what is and what isn't considered a mental health condition. The next piece in our puzzle is chronic diseases. The World Health Organization defines non-communicable diseases as conditions that are not passed from person to person, are of long duration, and have generally slow progression. They are a result of a combination of genetic, psychological, environmental, and behavioral factors. Using inside data, trends of the registered number of lives and admission rates for chronic conditions, including diabetes, hypertension, hyperlipidemia, epilepsy, and HIV were looked at over the last 2 years. So looking at diabetes, we have approximately 3 registered type 1 diabetic lives per 1,000 and approximately 51 type 2 diabetic lives per 1,000 in both 2022 and 2023. The all-cause admission rate for type 1 diabetes was significant at 61% and slightly lower at 48% for type 2 diabetics. But what does this actually mean? For every 1,000 beneficiaries studied, at least 3 of them may have type 1 diabetes, and at least 51 of them will have type 2 diabetes. And of all the lives who have each type of diabetes, 61% of type 1 diabetics are admitted into hospital, and 48% of type 2 diabetics are admitted into hospital. The number of registered chronic lives is the highest for hypertension or high blood pressure at 161 lives per 1,000. For all hypertensive lives, 42% are admitted into hospital in a given year. This can also be interpreted as, if you have hypertension, there is a 42% chance of you getting admitted into hospital. The number of registered chronic lives is the second highest for hyperlipidemia or high cholesterol. And for all hyperlipidemic lives, half of them will be admitted into hospital in a given year. Epileptic lives saw a 2% decrease in registered lives in 2023, with approximately 10 registered lives per 1,000. The all-cause admission rate for these lives was higher than some of the other chronic conditions. The last chronic condition we looked at was HIV, where approximately 43% of lives per 1,000 have HIV, with an increase in the number of registered lives in 2023. The all-cause admission rate for HIV is significantly lower than the other chronic conditions. We have now seen that chronic conditions such as diabetes, hypertension, and HIV are prevalent and can lead to substantial health challenges. At the same time, mental health conditions, including depression and anxiety, are equally imminent and impactful. However, what is less commonly discussed is how these conditions are interconnected. These pie charts show the number of mental health conditions that lives with different chronic conditions have. For all chronic conditions, between 15 and 20% of chronic lives have no mental health conditions. Majority of the lives living with chronic conditions have one mental health condition as well. 65% of type 1 diabetic, hypertensive, and hyperlipidemic lives have one mental health condition. For the other chronic diseases, 68% of type 2 diabetic lives, 60% of epileptic lives, and 71% of HIV lives also have one mental health condition. In a similar manner, a great proportion of chronic lives have 2 mental health conditions. 15% of type 1 diabetic, type 2 diabetic, hypertensive, and hyperlipidemic lives have 2 mental health conditions. 21% of epileptic lives and 13% of HIV lives also are living with 2 mental health conditions. This shows that significantly more than half of chronic lives have at least 1 mental health condition as well. Chronic lives with 3 and 4 mental health conditions are not as common, but these lives do still exist. Having a mental illness also has a multiplicative impact on the healthcare costs for chronic lives. We looked at healthcare costs per life per month using schemes in the Insight universe. Chronic lives without a mental health illness have 3.5 times higher healthcare costs than a healthy life. But for chronic lives with a mental health illness, this statistic increases to 6.8 times. Some reasons for higher healthcare costs for chronic and mental health lives compared to healthy lives include more frequent medical visits, greater complexity of care, long-term medication costs, diagnostic testing and monitoring, and more frequent hospitalization and emergency care. This can be broken down by the different chronic conditions. So diabetic lives with a mental health illness have 1.7 times higher healthcare costs than those without any diabetes, than those without any mental health illnesses. Hypertensive lives with a mental health illness have 1.8 times higher healthcare costs than those without any. Hyperlipidemic lives with a mental health illness have 1.6 times higher healthcare costs than hyperlipidemic lives without any mental health illnesses. Epileptic lives with mental health illnesses also have 1.6 times higher healthcare costs than those without. And HIV lives with a mental health illness have 2.8 times higher healthcare costs than those without any mental health illnesses. From this, we can see that mental health increases costs the most for HIV lives and the least for hyperlipidemic and epileptic lives. It is also important to look at practical examples of these interactions. The following two case studies are based on literature around this topic and focuses on these interactions in the real world. The first case study outlines an article published in the Diabetes, Obesity, and Metabolism Journal titled Depression and Type 2 Diabetes, a Causal Relationship and Mechanistic Pathway. The article highlights the reciprocating relationship between depression and type 2 diabetes that demonstrates that depression increases the likelihood of type 2 diabetes and vice versa. The effect of type 2 diabetes on depression focuses on the fact that many studies have suggested that type 2 diabetes increases the risk of depression. Hyperglycemia or high blood sugar, and dyslipidemia or high cholesterol reduce brain serotonin and increase chronic low-grade inflammatory disorders, which encourages the progression of depression. These chronic low-grade inflammatory disorders are linked to conditions including obesity, insulin resistance, osteoarthritis, as well as neuropsychiatric disorders such as schizophrenia and anxiety. Furthermore, insulin-resistant diseases have an impact on brain neuroconnectivity, cognitive brain processing speed, and cognitive dysfunction. Results have shown that 10 to 15% of type 2 diabetes patients have mild to moderate depression. Type 2 diabetic females are more at risk of depression than males, and the risk of depression is 2 times more likely for people with type 2 diabetes than those who are non-diabetic. On the other hand, depression also has an effect on type 2 diabetes. There's evidence that shows that depression might be a cause or consequence of poor glycemic control and in turn hyperglycemia. This is supported by the fact that antidepressant and anti-diabetic medications may be advantageous for the treatment of both type 2 diabetes and depression, since anti-diabetic medications improve cognitive dysfunction, which is an antidepressant effect. The symptoms of depression initiate the release of counter-regulatory hormones, which weaken insulin signaling and results in the advancement of insulin resistance. Also, the rate at which type 2 diabetes develops in depressed lives is significantly higher than the rate at which depression advances for lives who are already diabetic. The aspects that trigger the development of type 2 diabetes in depressed lives include poor lifestyle choices, tobacco usage, insufficient physical activity, and a diet deficient in essential nutrients. The conclusions from this paper was that the primary potential link between type 2 diabetes and depression is brain insulin resistance. And depression and type 2 diabetes are linked by the process by which infection leads to disease. This is due to brain insulin resistance, oxidative stress, and dysfunctionality of signaling pathways. The second case study outlines an article published in the Current Hypertension Report journal titled Anxiety in the Age of Hypertension. There was some evidence in support that a relationship between anxiety and hypertension exists. When compared to patients without a mental health condition diagnosis, individuals with anxiety and depression had high blood pressure detected earlier. Anxiety levels have also been related to the patient's knowledge of their high blood pressure condition. Individuals with high blood pressure who knew about their diagnosis were at higher risk of distress than those who did not know that they were hypertensive. Various factors were also analyzed that could cause an impact on both anxiety and hypertension, including occupational stress, marital stress, social isolation, low socioeconomic status, and racial discrimination. There is some evidence to suggest that anxiety can cause short-term increases in blood pressure. One investigation looked at how anxiety from public speaking caused changes in blood pressure. The results showed that when doing public speaking in an anxiety-filled environment, blood pressure spiked more compared to when doing public speaking in a neutral environment. Another investigation looked at 24-hour monitoring of blood pressure for individuals with panic disorders. The results showed that episodes of elevated blood pressure without simultaneous increases in heart rate were linked to panic attacks. Then there's also some evidence to suggest that anxiety can cause long-term increases in blood pressure. Several studies have used reactivity testing to predict blood pressure and provide more evidence about the long-term effects of anxiety. These tests are useful as they are able to demonstrate how the events would unfold in the real world. Results from a meta-analysis showed that individuals had a greater likelihood of increased blood pressure if they had stronger reactions to stressor tasks than if they didn't. Other studies that show a connection between long-term blood pressure and chronic anxiety suggest that conflicts around causality can be resolved using reductionist methods like animal models. The conclusions from this paper are that there's a fair amount of evidence to suggest that short-term anxiety can cause a rise in blood pressure. Anxiety may create obstacles to accurate hypertension detection, and anxiety treatment may be a helpful addition to hypertension treatment where anxiety is a key influence. So coming back to our theme of the day, how can we be the change? As medical aid schemes doing benefit design, we have to ask if current mental health benefits are still useful, if they are being driven by metabolic disease. Traditional healthcare approaches often treat physical and mental health in isolation, but considering both aspects simultaneously may lead to better outcomes. Moving forward, we should consider both aspects. Moving forward, we should focus on the importance of integrated and collaborative care approaches that address both physical and mental health to improve the overall well-being of individuals. As providers, we should ask if our disease management needs to change to allow for this interconnectedness. Some questions that need to be addressed include, should mental health screenings be integrated into routine checkups for chronic patients? And should we be investing in more multidisciplinary teams when treating patients? As a community, we need to make sure that there is publicly available information on how chronic diseases impact mental health and vice versa, in order to make sure that affected patients are well educated on their conditions. And at Insight, we can ask ourselves if we can incorporate this interconnection into our existing tools, such as the episode grouper and chronic care dashboard. So looking towards the future, it will be important for us to understand how different stakeholders, such as healthcare systems, policymakers, and communities, can work together to address these challenges. I would like to leave you with a quote from mental health advocate Debbie Hampton. Take care of your mind and your body will thank you. Take care of your body and your mind will thank you.